Hi everyone. Thank you for participating in the session that core hosted by ANACP and Kaga. My name is Yilin Son. So I'm the host today, and then I will be honored to present to you ANACP and Kaga briefly to begin with. So ANACP is committed to enhancing the clinical competency and the professional standards of physicians in North America through independent, evidence-based public medical education, academic exchange, and professional development programs, and also dedicated to fostering networking among American Chinese physicians in North America, reducing professional burnout, and strengthening professionalism. And for our KAGA, uh, KAGA stands for Chinese American Gastroenterology Association. We were established in 2024 and about to celebrate the second annual conference during Digestive Disease Week this year. We have over 60 members and we're still growing. Our organization aims to support professional communication, medical education, academic and practice partnership, and training employment opportunities. If you will be participating in DDW this year, welcome to our conference on May 3rd. I will post the detailed information in the chat later. We're also honored to have the panelists Dr. Wei Zhang and Dr. Li Minyu today. We will have Dr. Wei Zhang. He is a gastroenterologist and transplant hepatologist from Mass General Birmingham Hospital. He's also the director of Alcohol Associated Liver Disease Clinic to introduce the speaker. And the other panelist, Dr. Yu, he is a pathologist specializing in dermatology, pathology, and digital pathology. And he's the chair of Chinese American Pathology Association and founder of HiPatho, an AI-driven solution to empower hepatologists to deliver accurate and timely diagnosis. Now I'm going to hand over to Dr. Zhang to introduce the speaker, Dr. Yang. Well, I'm not sure if
Oh, sorry.
Oh, great. Okay.
Okay. Yeah.
Thank
Hey,
you.
yes. Thank you everybody for attending this lecture. It is a great honor to introduce Dr. Yee Hui Yeo. Dr. Yeo is a transplant hepatology fellow in the Division of Gastroenterology and Hepatology at Cedars-Sinai Medical Center. He has published over 150 peer-reviewed publications in numerous prestigious journals with over 10,000 citations. And he's currently a trainee committee member of ASLD Hepatitis B SIG. So Dr. Yeo's research is primarily focused on leveraging cutting-edge technologies, including user-centered, evidence-based approaches about statistics and advanced computing models to improve patient care and outcomes, with a special emphasis on chronic liver disease. He's a recipient of numerous awards, including Emerging Liver Scholar Award, the Vinay Sundaram Award for Hepatology Trainee, and the AGA Innovation Fellowship Award, the Kimberly A. Brown Transplant Hepatology Fellowship Award, and most recently, American College of Gastroenterology Junior Faculty Research Award, which is one of the most competitive junior research awards in the GI and the Liver Society. His work has been featured in major media outlets such as Time Magazine, Newsweek, Science Daily, and Washington Times, and among others. And so now it's let's welcome Dr. Yeo to give us an excellent lecture.
Thank you very much, Dr. Zhang, and good evening to everybody. That's a very, very kind introduction. My name is Yee Hui. I'm a transplant hepatology fellow at Cedars-Sinai, and today it's truly an honor to speak with you and with the title AI-Empowered Hepatology from Innovation to Clinical Implementation. So, but I want to begin with something very important. So today is really not a sermon about AI. I'm not here today to convince you that we should all rush headlong into AI adoption. Instead, today is really a talk about failure and lessons when we try to implement and adopt AI. So I want to share where implementation breaks down and why promising AI tools sometimes can fail in the real world clinical environments. So as we look at this slide, we all want to at least embrace and follow some of the AI products and try to see if we could be the first of them, one of the first to use some of the AI products in the clinical setting, like, even if this is like AI scribe, like there are many different products out there, and some will want to go above beyond and do the invent and take the lead. It's definitely an even optimal situation. But then the more important thing really is to how how to implement all these AI products, because there are just so many AI products developed every day. And then, so I wanted to share with you what I've learned about building the system, and not just somehow technically impressive, but also we want to see how we can achieve the feasibility, sustainability, and really usable for the patient. So that involves some failure, fine tune, and retry. So let's begin. This is the outline for today's talk. We'll first talk about AI's machine learning's domain, and then we'll spend a little more time on the large language model, the LLM implementation, and some of the products in the domain of hepatology. So first of all, machine learning. So in a very rough way, it can be categorized into two blocks. One is unsupervised learning and one is supervised learning. So for the unsupervised learning machine learning model, we had a paper in collaboration with Dr. Rajiv Jalan, a hepatologist from UK, and then my friend Dr. Jian Zhu from Xi'an Jiaoda University, and then and he's a mathematician, and then some of our uh, master degree students, Meng Yi and Lin Jie. And then, so for how do we use machine learning model to learn how we can help with patient with ACLF? First of all, we use the unsupervised learning to really answer a few questions. So rather than just start with the predefined clinical categories, we applied unsupervised clustering model to about 1,500 patients, all with ACLF defined using the North America criteria. So then we deliberately just avoid imposing any clinical hypothesis and just simply fed the baseline variables into the model and ask, like, first, how many distinct clusters can we categorize into? And then I'll skip all the details and all that technical part. I'll just tell you that we were able to just have the machine to divide the whole group into two groups category. And mind you, this is actually a 3D categorization. So when we break them down to 2D, then it becomes a lot of overlap. Actually, there aren't too many. And the second is, so what are the variables that actually drive the separation? And interestingly, we were able to see several variables that is acid-base related, and those acid-base related factors aren't really mentioned in the majority of the literature, especially those in the high impact factor journals. So we were, okay, maybe this is a good way to publish and let people know. So we were able to get this published early this year, and then after validate this in another cohort, and then also expand this not just within ACLF but also to overall population with acute decompensation. So with that, I quickly go to another project. So machine learning model, as we all know in the literature, it's mainly used in predictive model. So, and as we know, ACLF is a disease entity with a high mortality. So then we generated this predictive model, and we were able to develop a model and explain that, so then we can simplify the whole model and make it with a high accuracy, but a simpler one, and able to get external validated in a isolated cohort. We were able to generate a website so that in the future, anyone can just key in the 12 variables, and then the website will tell you overall the mortality in the 30 days with high accuracy. Second, the website can also let you know what are the variables that drives the patient to a negative risk, or some of the positive risk, meaning a negative survival, but some other factors that drive the patient to a higher survival rate. So then you can focus on certain variables, so and also treat accordingly. So this is a simple one, but then when we submitted this manuscript to Gastroenterology, we had a reviewer who made a comment that was quite painful. They mentioned that ACLS is actually quite dynamic. So if you use a baseline data to predict 30-day mortality, it actually ignores the evolving nature, right? So they were right. And because ACLS is not a static condition, all these patients with ACLF can be, looking to you, talking to you, but then deteriorate within hours, intubated, be on ECMO or on the dialysis machine. So then, so how do we really get into a real-time prediction? So our next project really is to see how we can develop a real-time prediction model. So then we were able to address this question from the previous reviewer. So as we already know that ICU patient, the situation is quite dynamic. So then a real-time updated method, which in our study defined as a model that predicts new extra hepatic organ failure within the next 12 hours. We want to see how we can develop that. So after many trial and error, we were able to generate a model that combined three components. So the first is a traditional machine learning model for structural variables, such as laboratory data. And there's another deep learning model that is specifically used for continuous time series data, like the hourly measured respiratory rate, heart rate, blood pressure, and some of the ventilator machine parameters as well. Then we have a third Bayesian fusion model to combine both outputs without overfitting. So then we were also able to address some of the problems, say the imbalance sampling method. And so then the result is actually quite impressive. We were able to have reached a AOC up to 0.83. And also when it comes to 6 hours and 24 hours, we were able to get a similar and consistent AORC, and able to have a pretty optimal calibration and decision curve performance. And also we perform external validation and sensitivity analysis in some other cohorts as well. So basically, this is a model that allows you to have a real-time prediction model. Imagine there are two scenarios. I would say first scenario is you begin your morning round at around 7 or 8 a.m. in the morning. Then if you use this, then this model will tell you in your shift for the next 12 hours, how many of your patient is able to will get some more extra hepatic organ failures. So that's the first scenario. Second scenario is, after 3 to 4 hours round, then you're able to get all these like hourly risk of extra hepatic organ failure. So then you'll be able to see some of patients may have an increasing trend like this patient. And some of your patients can actually be having a decreasing or downtrending risk. So then you can tell that, hey, during our round, all these past 3-4 hours, some of the patient actually getting worse. So you can focus more on those patients. However, uh, this is just the start of the whole idea, because if we really want to implement this dynamic prediction, there are too many hurdles in the way. So first of all, we still need some other studies to further validate and fine-tune this model. We even need a clinical trial to demonstrate the implementation efficacy and cost effectiveness of using this, and to really make sure that this can help the physicians, residents, everyone in the ICU, that this is really improving their quality of care. And third, to make sure we can implement, we need to make sure it's integrated with the EHR system, because otherwise you have to key in all these variable data all the time, which is not feasible. The last part would be the report system, the usability. So it's still a long way from being implemented, I just have to say. So let's shift the gears to another project that involve approximately 1,200 patients using DPMAS. So DPMAS, it has another name. It's called artificial liver. It's only used in Asia and European countries, but not really in the United States. So this is a study I work with Dr. Jalan from UK again, and then Dr. Chen from Chongqing, and then my student who is a master student in mathematics. So four of us, we try to analyze Dr. Chen's cohort, which is a prospective cohort study, and looking at standard of care versus DPMAS. In Dr. Chen's study, there isn't any significant difference between these two. But then in the past, there are some retrospective studies showing a significance. So what could be the reason to explain this? So I think it's likely due to indication bias in the previous study, like retrospective study. However, is indication bias the end of the world in observational study? So my answer to our group is actually it is not. So we can actually leverage that by changing the whole question. So we don't really ask the question about whether SMT or DPMAS, which one is more helpful. We change our question to which are the patients who are more likely to benefit from DPMAS. So you're really identifying patients who will get benefit from DPMAS, but not really compare between these two interventions. So this can also be done in the traditional way, say, you compare these and you do a subgroup analysis. However, in subgroup analysis, usually these people, the variables affect the outcome at different extent. Some of the variables are nonlinear. Interaction between variables are very, very common. So then subgroup analysis itself are really not helpful. So there we go with a machine learning model. So in this study, we aim to estimate the individual treatment effect. So to address this, we referred to a JAMA paper who also had studied a framework to estimate the individual treatment effect or something else. In their study, they are looking at the oxygen target in patients who get ventilated. So we basically adopted the same machine learning model, and then by looking at this, so it's very straightforward. So we pull all the patients, right? We pull all the patients, which include those who receive DPMAS and those who receive standard medical care. We pull all of them, and then we trained in using a supervised learning model, using mortality as an outcome. Then for each patient, you'll be able to get two probability, which is if this patient ever received DPMAS, then this is the Y is the probability of mortality. And then if the same patient actually received the standard of medical care, then this is the more probability of being passed away. So then using a very simple subtraction, then you'll be able to get the individual treatment effect. So with that, we will be able to say, we'll be able to get the ITE, which is the treatment effect of everybody. And then this is the distribution of everyone's, the 1,200 of patients. So we'll be able to get three patients group. One is the high benefit group, in the indeterminate group, and the low benefit groups. So when you look at the absolute risk reduction, so the ARR for this first group, it can be up to almost 30%, whereas the ARR for this group is actually negative. So for this group in the middle, I would say I like to categorize patient into three groups, mainly because even though we have a good machine learning model, we still need clinical judgment. So these are the people who need clinical judgment from the physicians to see if they really will get benefit from DPMARS or not. So just a quick outcome. So the signal is quite striking. So in the 5 high benefit group, the adjusted hazard ratio for DPMARS versus the standard medical therapy can decrease to 0.13, which is a very significant decrease in the mortality risk. Whereas in the low benefit group, which are the patient with the red color bars, the risk of mortality in this patient, when you apply DPMARS in this patient, actually they have a much higher risk of having reaching a mortality. So this is the calibration curve analysis and decision curve analysis. So we also study the low benefit group, like how come they do not really get benefit from DPMARS. So then from this, you can categorize this group, the red group, into 3 groups. And you can tell that some patients are really too sick to get DPMARS, whereas some patients are too light, like the disease severity are too mild to get them to benefit from DPMARS. They can actually just, they don't really need DPMARS, they can just get the SMT. So again, the question for many studies, really not to see whether or not an intervention is efficacious, but really is whether or not we have applied this to the right patient. And this study idea can be applied to many other study in the field of oncology, the field of GI, and many others. So again, just to summarize, in the field of machine learning, we've done a few studies in both unsupervised and supervised learning. So next, we'll get into the LM implementation. So first study, I just want to let you know, we focus on alcohol-associated liver disease, and I have really learned a lot from our really pioneer in the field, like Dr. Zhang from MGH, who has done a lot of groundwork in really making breakthrough finding in the field, and also develop cohorts to help the patients. So in patient with alcohol-associated hepatitis, both AGA, ACG, ASLD, in all these clinical updates or the guidelines, we advocate for both medication and psychotherapy. However, in the practice, psychotherapy rarely happens. It could be due to the shortage of the trained therapists. It could be due to the limited insurance coverage or stigma. You name it. So then, so the result is there is a persistent gap between guideline recommendation and the real world delivery. So then this is clearly an unmet need in the field of alcohol use disorder. So then my mentor, Dr. Spiegel, he and Dr. Liran, another mentor, they generated this AI VR system. So in short, this immersive VR system is able to get a scenic landscape, whether or not whether this is on the mountain, in the forest, by the seaside. Then in this VR, you are able to get really calm down, and in this really soothing and comfortable environment, you interact with a robot psychotherapy, and who is developed by Dr. Liran. So he's a psychiatrist and also a full stack developer. So they published their first published paper in the NPJ Digital Medicine to treat patients with IBS and anxiety. So for me, I incorporated motivation interviewing, which is a practice for us to help people to reduce their alcohol use, or really to quit alcohol use. then to help them to incorporate this and the CBT that's previously helped to patient with anxiety and depression to see how we can change the behavior. So this is how it is like.
Meet Zaya. Created and tested by clinicians at Cedars-Sinai, Zaya has been trained by experts in many forms of therapy. She's a gateway to unburdening your mind without judgment and safeguarding your private thoughts with discretion. She's always there, ready to listen, understand, and help. Zaya transforms the ordinary into extraordinary to magically bring you into worlds that enhance your therapeutic experience and take you beyond healing into new levels of growth and awareness in ways never before possible. Zaya is always there, ready to listen, to engage, and to talk about what matters most to you. So, how can I help?
So we are very proud that this is one of the first products in the Epivision Pro. And then, so we launched my first trial about 1.5 years ago. And we, in patient with alcohol-associated liver cirrhosis. And then we were able to get a pretty high score for the usability scale. And when we interview the patient, this quality study really teach me a lot on how patients look at their relationship with the robot or psychotherapist. They think that even though this is the first time they meet with this robot, even though this is only about 30 to 40 minutes of interview session with this new psychotherapist, they were able to develop this positive relationship very quickly and then be opened. And some of them mentioned that they found the positivity. When you really ask them, hey, what was the reason for that? And anything that make you able to be open to this new therapist, some of the advantages they mentioned are non-judgmental communication and how they are so intelligent to identify things that can lead to a trigger to alcohol use and help them accordingly using different types of coping mechanism and method to ensure that there is an increase of readiness. However, about 1.5 years ago, that was the version that was not the best. So there are people mentioning that even though this is a robot, they feel like they're still talking to a machine. And then back then, the latency time on average is about 2 seconds, 2.6 seconds. And now that's much better now. So then sometimes you can feel like this is more like a robot when you only say, hey, thank you. And even an answer to the thank you can take 1 second too, which means that this is really a robot behind this. So make it kind of, not close to human in that sense. So then some of the people criticize on the appearance or the voices. And then they also feel like they may not be able to use it when it's at home. They may need a lot of help in troubleshooting. So then we really gain a lot of experience. So when we implement, this is an ongoing project that we pivot to inpatient. So there are several reasons why we pivot this VR to inpatient, mainly because, first of all, this is a teachable moment. They just suffered from alcohol-associated disease, which can be withdrawal, which can be pancreatitis or anything else. And then they just suffer both mentally and physically. So then this may be the best timing to increase their readiness. And then, and also since this is a protected environment, they can use this VR whenever they want, right? So then in our first trial, we only focus on the feasibility, usability, and safety because the workflow is the most important thing. If you want this sober VR, we call this sober VR now, not Zaya. If you want this sober VR system to be successful, I think the first person you need to ask is our nurse partners, because as our really dear partners, we don't want to interrupt our nurse work schedule, right? So when we deliver this, we want to make sure that this is not interrupting their work in delivering the medications or getting their blood, all that stuff. So we engage with patient and nurse to see how we can co-develop a protocol for inpatient use. So once this is done, then we'll be able to see that how this sober VR intervention can increase their readiness so that they are more willing to get to linkage to care to IOP. So IOP named Intensive Outpatient Program. So if we are able to get them be more ready or more willing to engage in this almost like weekly treatment for the as an outpatient, that will be super helpful to make sure they stay sober. So so that's super important because early abstinence can be translated to higher likelihood of recompensation, especially for those patients with alcohol-associated cirrhosis with decompensation or alcohol-associated hepatitis. So next project, I want to briefly talk about hepatic encephalopathy. So we learned a lot from this project. Initial idea we were having was to develop a remote monitoring for anything about decompensation. So we generated an app and then try to see if we can link that to Apple Watch, because Apple Watch really monitor patients' sleep cycle reversal, the sleep quality, and really to see whether or not the sleep get interrupted or reversed. And then Apple Watch is a best tool for step count, heart rate, all that stuff. And then in this app, we were able to get a questionnaire and then get some games to test for hepatic encephalopathy. We actually convert the whole PHES, all these tests into an app version. So that we also generated lab data, have some area for them to key in the lab data and have education. So this is how some of the games that's listed here. But then we got a lot of barriers. So some of the dilemmas include boarding of the patients. Now I'll show you this. This is the boarding of the patients. And then even with just keying their email, generating password and validating this in their own email address, this step we lost about 10 to 15 patients, because a lot of our patients are older, really not having high medical literacy or even digital literacy. So then so without a good digital literacy, it's really hard for them to adopt this as a new habit. And even for people who are able to get on board, then a lot of them, they don't use it they probably use it for the first week or two, and then they don't want to use it anymore after that. So because to them it's just another app, like this, that like you have a cell phone with so many different apps, you don't want another one, right? So they get too tired. And then and especially for people with decompensation, they're always like, you know, having sleep cycle reversal. They feel drowsy in the daytime, so they leave. They need their family members to help them to nudge. So more importantly, who should be liable if there's any, you know, problem, or let's say if any of these sleep cycle or heart rate, or if the patient happened to have hepatic encephalopathy, anything, then they key in and then they did not get any response from the physician side, then who should be liable? So then this study, we failed a lot because we did not consider the feasibility at home and the usability, and also we did not consider how to treat and improve the sustainability. So we changed. We changed into not another app anymore. This is a WeChat app in the current version. A friend of mine, Cindy, she helped me to generate this WeChat app, converting every single thing of the sorry. First of all, we narrowed down only to hepatic encephalopathy only. And then we get them into WeChat app. So then in the future, patients do not need to verify using their Gmail, email, anything. It will just need a QR code, and then they get boarding within seconds. And then not only we include the patient, but also we include the family member. So then in their WeChat contact list, they will have our contact, and then they pin our contact, and they also pin their family member. So if there's any events that we need to talk to the patient or contact them and or the family member, then it will be easy for them to be reminded or to be contacted. Second, we narrow down a lot of questions, so then it's currently a quick questionnaire, and then and the user interface and design is super easy to use, only because everything is similar to WeChat, and they use it all the time. So and mind you, this is a study that we shift and only do it in China. Then so we also convert all the PHES tests into this app. So then now it's really the first of its kind WeChat app that combine patient, the family member, and the physicians in the same loop. So with this, then we involve multiple hospitals in China to start our first project to really look at the feasibility and usability of this app. So this is how it looked like. So instead of many different pages, now it only contains three pages. One is check-in with a short question there, and then PHES test and several health education articles. So daily check-in only includes the key-in for the blood pressure, whether or not they feel fever, and even fever is a subjective fever because you really. But when they hit fever, there will be another sign to ask them to get a thermometer. But it's okay if they don't have that. So we get them a sleep emoji, and then we only ask them to fill in very simple and WeChat user interface like thing and some emoji to represent their condition today. So then, and there will be all for the questionnaire, and then there are some. This is the English version, but then you'll see the Mandarin version very soon. So this is how it looks like. This is the previous version actually. We have some updates to this to the new version, so it make it very easy for patient to key in and also to hit submit. And this is the strip test. This is a test for calculation, and this is the zero dots connection. And this is ICT, the inhibitory control test. So then they are able to link to the patient's family member. And then if there's any alert, then there will be then this is the physician's dashboard to really know that their patient's situation. So really, that is another app that we try to see how we can remotely monitor a patient with hepatic encephalopathy and or some other decompensation-related early symptom signs that can help to improve the patient and physician's relationship, can really help the physicians to retain the patient in their clinic or the hospital. And it also helped to get the patient's family to be involved. So for now, we are still doing our first project, and hopefully we can get some positive news. Next one, but not last but not least, is the post-transplant care. As a transplant fellow, it's always frustrating to see, a lot of challenges after transplant. The first of all is the medication reconciliation, and it is without any question. So we start doing medication reconciliation when we are the first year intern. And everyone who did this know how painful it is, because you always have to call the patient or get to the bedside to ask patient, and then sometimes patients do not really speak English. Sometimes the patient are too old to know how to even pronounce or spell the medication, and then get you to a lot of puzzles that you really don't know how to get to the whole list. And most importantly, it takes a lot of time. Right, so then it only get worse in patients who already got transplanted. So they have to take up to 20 pills a day. Some of them are even twice a week, like Bactrim, for prophylaxis. So then with all these, not to forget that the prednisone is tapered. So then they have to, let's say they take 5 pills of prednisone steroid this week, and then these 5 pills will become 4 next week. And all these tapering plan can be interrupted by having an infection, getting rejection, or if they ever get a procedure after the transplant. So there are really high rates of incorrect use, not because they don't want to use it correctly or being compliant. It's just because there's just so many different prescriptions and different advice from different physicians before discharge. So then we developed this voice agent to call them. So this is a robot who can call the patient, and then and it's trained by the top 250 medication in the United States. And so then it is very sensitive to the medication name and the pronunciation and the spelling. So they can call all the patient at once. They can speak multiple different languages. So I generated this model, and then I tried using different curveballs. So these are the curveballs that in this scenario that you will see very soon.
Hello, this is Kate calling from Dr. Yeo's hepatology office at Cedars-Sinai Clinic. May I please speak with John Doe?
Yes, this is him.
Thank you, John. I'm calling to quickly review your current medications to make sure your chart is accurate before your upcoming appointment. Do you have your medication bottles nearby, and are you available to discuss what you're taking right now? Or would a later time work better?
I have my bottles nearby, but I need like 30 seconds to take it.
No problem at all. Take your time. Just let me know when you're ready to start.
Okay, I'm ready.
Okay, all
I'll
right.
list
So
some
then
medications
we'll
listed in your
key.
ready. Please tell me the name, dosage, and how many times a day you take each prescription medication.
Okay, so the first medication is the transplant medication. It's called tacrolimus or tacrolimus. It's TACROLIMUS.
So as you can see, this is not even the correct
Thanks for
spelling.
filling that out, John. Do you please tell me the dosage and how many times a day you take tacrolimus?
Yeah, it's 4 milligram in the morning and 10 milligram in the evening.
It's apparently an incorrect
Thanks,
dose.
John. Just to confirm, you take tacrolimus 10 milligrams in the morning and 10 milligrams in the evening, correct? And how
Oh,
many
sorry.
times a day?
It's 5 milligram in the morning, 5 milligram in the evening.
Got it. 5 milligrams in the morning and 5 milligrams in the evening. Do you take it twice a day then?
Yes.
Thank you.
So then
I
when
forgot
we
the dose.
skip into the later one,
No worries, John. If you remember later, you can let us know.
so
Meanwhile,
even though we
do you have
forgot
any
the
other
dose of Bactrim, it's fine.
Yes. I'm taking Lasix, furosemide. Sorry, I also
So
forget.
fast
you
forward.
take each day?
It's 300 milligram before sleep.
Thank you. So you take gabapentin 300 milligrams every day?
So
Now,
at the
do you
end
take
of the
vitamins or herbal steam?
conversation, the robot is able to generate a list.
So 2 to 3 nights a week for sleep. Is that correct?
Yes.
Thank you for confirming, John. I've updated your medication list accordingly.
And then I'll also show you some other. So it's also multilingual, can speak Mandarin, Spanish, and Korean.
Estoy tomando metformina 1 gramo 2 veces al día.
Gracias por la información. ¿Tomas algún otro medicamento recetado?
Sí.
인슐린을 밤마다 10유닛을 이렇게 배에 놓거든요.
인슐린을 복용 중이시군요.
네.
인슐린은 주사제라 복용 방법이 조금 다를 수 있는데 용량과 하루 몇 번 주사하실지.
So we thought that this is a good product to launch, but then our first lesson to learn is that patients really don't pick up the phone call when we call them because there are just so many spam call all this time, right? So a lot of patients, they don't really want to, and too many, and then there are some information mismatch. So then we were able to fix this by generating a workflow. So using a new product called NAN, it is a AI automated workflow. So then we were able to, first of all, fit this workflow an Excel sheet of the patient like this one. So then this is like the Excel sheet with the name and the phone number. And then this the other two are blank. Then once it is triggered, then this can be a 50 patients list to begin with. So then the next step would be another company called Trilio. Trilio can help us to send message to the patient and tell them that, hey, John, this is Kate, and then we'll call you in about 50 minutes. So then please gather all your medications before the call. So in this case, patient will really pick up the call. And they also, before picking up, they will prepare the pill bottles before the call. So this makes the whole workflow much better. So then next step is after the call, then we'll be able to fill in these two. The first one is the true medication list for the patient. And the second one is a transcript. Because a lot of time, when you eventually found an information mismatch, you really don't know whether or not this is the patient who forgot about their medication or it is the AI's problem, right? So with this transcript, you'll be able to trace back to see which is the source of the information mismatch. So we were able to get to this step, and our next step is to hopefully automatically input the medication list into Epic system or Cerner system. So, and that ends the discussion today. And I wanted to thank my mentor from Cedars-Sinai and collaborators from Stanford, Xi'an Jiaotong University, UCL, Dr. Jalan, and Chongqing Medical University, Dr. Chen. And thank you for attention. And I want to tell you that I've learned a lot from the implementation of all these studies. And then in today's panel, Professor Yu, he's also a big name in really help us to implement AI in the field of pathology to really know how, thinking from the mindset from pathologists, I wanted to hopefully see if we can get some experience from him to see how his product really be implemented while also taking the user, aka the pathologist's need into account. So, and thank you. After Dr. Yu, we will happy to get everyone's questions.
Yes, thank you so much, Dr. Yang, and this is a very impressive presentation. I have to say you covered almost every AI technology and we have developed from the traditional, now we call traditional, actually now we look back, it's really innovative, but because it's the fast progress of AI technology, people get more familiarity with the machine learning and supervised learning. So you mentioned about how to do machine learning and also the neural network. That's very quite impressive. I think the most significant is how you implement this when in a consumer-based market. And most of the technology we have done so far is really targeting medical professionals, but it's very eye-opening that to see that you implement this technology to target the patient, which is really should be the ultimate goal of all our technology. That's very impressive. A couple of things I want to see that from my experience developing AI in pathology, and one thing that I was involved in developing a FDA approved pathology AI algorithm. Yes, I was actually involved in developing AI in liver pathology, and that is FDA approved. The purpose of that AI technology or driving force is really the inconsistency between pathologies when we evaluate liver disease. There's a different grading systems, but there's poor consensus among pathologists. Then we develop this algorithm that can reliably and consistently evaluate the liver disease and particularly the cell damage and also structural distortion and caused by the NASH. So that is how we see that how the pathology can really help and work with the GI or hepatologists in this field. So I want to see that it's very encouraging to see Dr. Yang has done such a tremendous work, and then I'll be happy to collaborate in any way, then so we can help each other and finally help our patients. This is all I want to see, and I'll be happy to answer any questions if there's any in the QA session. Thank you.
Thank you very much, Professor Yu. Dr. Zhang, any comments? Sorry, you're mute.
Well, thanks for this for such a fantastic presentation, and because as a hepatologist, I think what you have developed is really not only just develop the AI diagnostic tools, but also actually develop patient-centered tools, especially that impressive VR based psychotherapy for patients with alcohol-related liver disease, which is absolutely needed. And also the hepatic encephalopathy, I think that's like a platform or an app, right? That you develop to manage those patients with hepatic encephalopathy. And those are really robust tools that can really benefit directly our patients. So I mean, well, before we open up the session, I have a question, about the tools that you developed. I've done some qualitative studies. I think most of our patients are quite resistant to AI agents or tools, especially those AI tools that interact with them directly. Partly one is there's their HIPAA stuff, right? Some of the information is very sensitive. Number two, because it's they don't feel that they're talking to a human being. So those are some of the barriers that that I have identified during those qualitative interviews. So I don't know if you have any suggestions or anything based on your experience developing tools for our patients.
Yeah, very good question. So first of all three studies, the alcohol VR system, the hepatic encephalopathy, and the last one that is the call agent, so the voice agent. These three are HIPAA compliant to begin with, so then it really helps. But the way to get HIPAA compliance is different in each of these studies. For example, the HIPAA compliance in the first study, the AI VR system, it is because Dr. Liran, he himself generated a Microsoft Azure-based HIPAA compliant database to store all these. So all the API of the this large language model are only processed and handled within that environment. So that's the way we make them able to get HIPAA compliance. The second one, which is the voice agent, the company itself that provide this product, he itself is HIPAA compliant already. So I basically modify the product they have to become a medication reconciliation robot. So they also can be modified into, let's say you have a receptionist to help you to schedule colonoscopy, upper endoscopy. It can be easily modified to different purposes. So then that's why it is taken care of at the very beginning. I did not have to worry. And then the WeChat app, which is also a question in the audience, is in China, there's this policy called I forgot the whole name, but it is something like 个人资讯保护. And then so there's this database, it's called 等保三级数据库. Then if you are involved any kind of health-related data, then you have to make sure that this is compliant with this 等保三级 database. So that's why we were able to confirm that the data in the WeChat app is also compliant to the China's version's HIPAA policy. So to your other question about whether or not how to really help them to adopt this AI product, it's difficult, really. So then we, for example, in our AI VR product, when we include the patient, I have to say many of them actually say no, they did not even want to participate, right? So then definitely my first study has a selection bias, meaning that if it is efficacious, let's say, it will only be benefit for people who are willing to use this at the beginning, right? So unfortunately, we cannot really commit to every single patient with alcohol-associated liver disease, but at least some people, especially the younger one, now that a lot of people, young people have ALD, so then they are more receptive to this agent. We don't have any problem with the call machine because they call and then they help to do the work. And same thing to the hepatic encephalopathy. Now that it's more user friendly, only because this is a WeChat app that they are very used to. If no other question, I'll start answering some of the questions in the audience. So how to avoid the AI hallucination and detect this? Now, it's really a big topic in the field of large language model. So in the AI VR machine, I would say there are at least 6 different large language models running behind. So then, and some of them cross-check each other. So to make sure that the content generated by one is not having any hallucination. So then with this cross-checking method, then it's really reducing the rate of hallucination. However, there's even with this, you still can expect maybe like 1 in 1,000 or 10,000 chance of having hallucination. So that's the beauty of doing a AI therapist, because let's say if this is a product, say this to provide medical advice, then you really want to avoid using large language model in this situation. At least I will avoid, because if let's say this one case of hallucination leads to any kind of medical legal issue, then the company will have to be liable, right? So in my product, the AI VR one, very often patient can refuse, because this is a two-way communication. A lot of time that the robot say, "Hey, you look anxious. Why don't we do a breathing therapy?" The patient can say no. Patient is like, "No, I did that before. It's really useless." With this kind of two-way communication, you can always refuse. So even if there's a hallucination, then patient him or herself can say no or just refuse to answer all those questions. And so that's how we deal with it. If this is only the one-way communication, say patient ask the question and then robot provide the answer, I would be worried. So that's how we avoid this kind of hallucination related problem. And then there are, and thank you, Dr. James Moon, always respected researcher in the field, and then and very well-regarded clinician. Then the next question from Hao Peng is, there are some definitely there are some models developed in the EPIC system. But I have to tell you that even though sometimes EPIC is a very competitive competitor, the advantage that we have, or that some of the companies have, are how you are able to implement. So the accuracy and the capacity is not a problem anymore in many situations. The problem is how you implement this, how you really, from the angle of the user, aka you are the clinician or you are the nurse, then how you really know the pain point when developing or implement all these things in the clinical setting. So I'm not surprised if this is underdeveloped under EPIC or even some other bigger company. But then you just have to know that you are the person who is practicing every day. so you know how to do it the best. Then there are some other question about the different languages, and yes, we mentioned about we demonstrated the Korean, and in fact, the company the model is best in English, Spanish, Italian, Germany. It's not so good in Mandarin that I can do the testimonial. You can feel that that sounds a little bit like an ABC, and same as Korean. Um, so I I will leave my email address in the contact list, the chat group, and then happy to collaborate or get any further question.
I want to add a comment about the hallucination. That's a great question, and is also one that really concerns all of our us as medical professionals. The most common approach to address that is to use a technology called RAG. That is like a very specific source of information, more like the ground truth you want your large language model to base on. So you can think is that a fine tuning of a large language model, no matter what it is, it can be a ChatGPT or kind of Gemini, and or it can be Llama. Then you have a local copy of this LLM. Then you feed the RAG, which is really ground truth. It can be any guidelines of from your clinical practice or from textbook or from any scientific research papers to use that as a fine tuning for the LLM. So with the large language model is used for any chat-based AI, then actually they rely on RAG, not what they are previously trained on the general information. So this one way to address that. Another comment I want to make is that we talk about Epic. The EHR, I think, gonna be a big. You can think it can be a bigger help or can be a bigger barrier for AI, because to a great extent we rely on EHR for all the clinical information. If EHR providers is a collaborating with us, like actually that's a soup boost for the AI developers. But if they try to block the development, that can make your life super, super hard. Something to keep in mind, and but that is the reality in the US as the EHR medical landscape system. Yeah.
Thank you very much, Dr. Yu, for the additional comments. Yeah, RAG is really a good tool in terms of retrieving data from any kind of database. And then I saw that there's another question from Dr. Song about the current level of integration with Epic or other EMR. I would say there are some AI scribe that's super helpful, like a bridge, ambience. They are able to key in all this information to become a useful note and be implemented and integrated into Epic system. I'm not aware of too many other tools that's already able to get us into, because there are some technical barrier behind this. Hopefully, in the future, we'll be able to do it. And please let me know if I miss any question. Happy to answer.
I think you already covered most of the questions.
Can I ask a quick question I put in the chat? What's the name of that company you used for the medication reconciliation?
Yeah, of course, of course. There's no secret behind this. It's called Retail. I'll get you in the chat box. It's called RETLL, and then there are many companies behind this to do the similar stuff. But Retail is one of the best. It's also very cheap. So then, as a fellow, I need a really cheap product to start with, but it's really impressive in terms of function. So and Retail, I first know about Retail because one of the private GI is using Retail to schedule his colonoscopy. So then a lot of dental clinic, orthopedics clinic out throughout the country already use it for their reception. So you just need to modify this to become, I also modified this Retail to tell my patient, hey, this is the day to end your antibiotics. or this is the day what time do you take your tacrolimus the night before the blood test, all that stuff. So that it can be very specific.
Great, thank you so much. Such a nice talk.
Thank you.
I recently went to the Society of Hospital Medicine conference. AI is a big topic, and everybody is get very excited, but also a lot of concerning. And so wonderful talk today. Thank you very much.
Thank you. Now, there's a lot of trial and errors. And as I mentioned, I failed a lot of times. And this is just a sharing of a lot of lessons we learned. Okay.
If you still have time, there's only one last question about average cost for each call.
It really depends. So it's actually very cheap. I think it's a few cents. But at the initial phase, it's for free until you develop and publish this model. So you really use it at a very, very low cost until it is ready to be a product, so to say.
Thank you.
Okay.
Well, if there's no further question, we'll just wrap up this amazing talk today. And then Dr. Yang is really nice and then left his email address in the chat. So feel free to reach out to him if there's any further question or collaboration. Thanks, everyone.
Thank you very much.
Thank you.
Take care.
Bye-bye.